Hello to everybody. I'm very glad to have this webinar. It's a LINNC online webinar dedicated to the embolization of the middle meningeal artery to treat the chronic subdural hematoma. So, of course, we have two speakers that will be giving the talk today and inform us about the latest development of this treatment. So first of all, we have Dr. Dominik Vollherbst, who is working in the Heidelberg University Hospital in Germany. Good afternoon, Dominik. And the second speaker is Dr. Gal Yaniv from Tel HaShomer Hospital in Tel Aviv, Israel. Good afternoon, Gal.
Hi, everyone.
Hello. So the embolization for middle meningeal artery to manage the subdural hematoma is a quite brand new indication. It's an old technique, but it's really a new indication, which is a kind of revolution because it's adding a new spectrum of the pathologies that we can treat through endovascular approach. So we'll be reviewing several subjects, including the epidemiology, the morbidity and the mortality, clinical background and all the ongoing trials on this topic, the traditional management and the clinical diagnosis, the pathophysiology, the treatment option, the treatment techniques, the risk and the complication. So for all of you who are following us around the world, you have the possibility to take advantage of a chat. So it's very easy. You can ask any question you wish to the speaker, and I will be your loudspeaker. And you just have to click on your screen. So I want to especially thank Medtronic and Nadine Hans, who was at the origin of the organization of this webinar. So let's start, first of all, with Dr. Vollherbst. Will be giving an update of several important topics. Dominik, it's your turn now.
Thank you very much, Professor Spelle, for the introduction. And I will present you the MMA embolization for the treatment of chronic subdural hematoma regarding pathophysiology of this disease, embolic agents, and I will also focus on the evidence on this new treatment. These are my disclosures. And this is the agenda for my talk today. I will talk about what is a chronic subdural hematoma and how frequent is it. I will focus on conventional treatment, the traditional treatment options. Then we will have a look at the pathophysiology of this disease. I will give you an overview about the embolic agents which are used and available. We will talk about the indications and then about the evidence. So what is a chronic subdural hematoma? A chronic subdural hematoma is defined as a collection of blood at the surface of the brain, localized between the dura and the arachnoidea mater. It is mainly caused, this is the basic theory, by a tear of bridging veins leading to hemorrhage, which can happen over days or months. It is frequently observed in elderly patients, often after only mild trauma, and especially frequently in patients who are treated with antiplatelets or anticoagulants. We as radiologists define a chronic subdural hematoma as a subdural collection of blood, of which more than half of it is either iso or hypodense to the brain parenchyma. And it is important and interesting to know that acute hemorrhages appearing hyperdense on CT are observed in about 8%. Regarding the clinical presentation, I think the most important information here is that the clinical presentation is highly variable. The most common symptoms are cognitive impairments, gait instability, headaches, and also hemiparesis or other focal motoric deficits. Another very important message from my talk is that the chronic subdural hematoma is a frequent disease, and in the future its incidence will increase. According to a current study, the current incidence in the US is about 13 to 17 cases per 100,000 patients, and the incidence is increasing. The reasons for this increasing incidence is the aging population, and on the other hand, increasing use of blood-diluting medications such as antiplatelets or anticoagulants. And if we compare the incidence of the chronic subdural hematoma with other neurovascular diseases, it is even more common than unruptured aneurysms. And as I said, the incidence will rise in the future year, making this disease very important for us. So we now look at the traditional treatment methods. These are surgery, more frequently applied than the conservative non-interventional management. General recommendations for surgery are the patient having symptoms and larger chronic subdural hematomas. There is no strict diameter when hematoma should be operated, but in most studies it's about 10 millimeter or above, or a significant midline drift of 5 millimeters or more. And the data regarding these conventional treatments are rare, so there are only a few prospective studies, and there are no randomized controlled trials regarding the conventional treatment management. We now have a short look on the surgical treatment. Most of the times a craniotomy is performed and then followed by a hematoma evacuation. Sometimes only a small burr-hole trepanation is performed with or without the insertion of drainage. And there are also specific subdural evacuation port systems available for the treatment of chronic subdural hematoma. There are major drawbacks of these conventional treatments, and the main drawback, the main limitation here is the recurrence, because recurrence after surgical or even conservative management happens in about 10 to 30%. Furthermore, the management can be challenging if the patient needs antiplatelets or anticoagulants, which might be a contraindication for surgery. And also in elderly patients with several comorbidities, surgery might not be possible, limiting the treatment options for these patients. We will now have a look at the pathophysiology of chronic subdural hematomas. Often the beginning is a traumatic brain injury, but it is not mandatory. This can lead to a tear of the dural border cell membrane, which thus leads to leakage of CSF and blood into the subdural space. This leakage leads to the releasement of cytokines by the dural cells, which is especially VEGF. And this attracts inflammatory cells, mainly neutral and eosinophils. These inflammatory cells, together with collagen, form so-called neomembranes. And these neomembranes want to be supplied by blood, which is even increased by the cytokines like VEGF. And this leads to a development of immature fragile blood vessels. And these immature fragile blood vessels are prone to leakage and rupture, which leads again to the leakage of CSF and blood into this subdural space, creating a vicious circle which keeps the subdural hematoma alive. So what's now the role of the embolization of the middle meningeal artery? Its aim is the devascularization of the meninges, and by doing this to decrease and prevent recurrent hemorrhages into the hematoma. Its aim is to break this vicious circle of repeated bleeding and inflammation, and then to facilitate the physiological absorption of the subdural collection. With the MMA embolization, we want to change this disbalance from hemorrhage and leakage to a resorption towards resorption of the hematoma. This is an overview of embolic agents which are used for the embolization of the MMA for the treatment of chronic subdural hematoma. On the one hand, on this slide on the left side, we got the group of the particulate agents. And here most frequently used are microspheres. Here's just an example for the Embosane microspheres. These microspheres which are used are nothing more than just small plastic bubbles, plastic balls, which are injected into the MMA. And on the other hand, we have the group of liquid embolic agents. We can divide this group in the glue or cyanoacrylates. Some famous materials here, histoacryl or glubran. On the other hand, we have the copolymer-based agents. Most famous one is onyx, but also squid and fill. With a deeper look into onyx, as this is one of the most frequently used devices here. Onyx consists of ethylene vinyl alcohol copolymer together with tantalum powder, which causes the visibility and DMSO. Onyx should be shaken for at least 20 minutes before we use it. And there are several subtypes, of which only Onyx 18, the least viscous version of Onyx, is really used for the embolization of the MMA. It produces artifacts in CT imaging, which have no relevance in MMA embolization procedures. We have now a look at the mechanism of vascular occlusion for these EVOH-based embolic agents like onyx and squid. So the embolic agent is injected into the blood, and the bloodstream transports the DMSO away. This is followed by solidification of the active substance, ethylene vinyl alcohol copolymer, which is called precipitation, which occludes the vessel. Some interventionalists say that these copolymer-based agents might have a better control, higher efficacy, or are even safer for the treatment of chronic subdural hematoma by MMA embolization, and we will get back to this question a little bit later in my talk. First, let's have a look at the evidence. The first case report on this new treatment technique was published over 20 years ago in the year 2000 by Monday and colleagues. And in the following years, especially in the last 5 years, there were several studies published, numerous retrospective studies, a few prospective single and multi-center studies, and several meta-analyses. And especially in the last 5 years, there was something like an explosion of papers and clinical interest into this new field. One of the most important studies here is the study by Bahn and colleagues published in Radiology in 2018. It is sometimes called the blockbuster study for this new technique. It was a prospective monocentric study reporting on 72 patients who received MMA embolization with microspheres. And this group was compared to a historical control group consisting of 469 patients. The primary outcome parameter was treatment failure. This is the summary of the results of this study. Without surgery, there was no case of treatment failure for MMA embolization, and there was a treatment failure rate of over 80% for the conservative group. With surgery, for preoperative embolization, there was only one case of treatment failure, according 2.2% treatment failure rate, and there was a treatment failure rate of nearly 20% if no embolization, only surgery was performed. And these results might explain you why this study is considered as the blockbuster study and caused, together with, of course, with other studies, something like a rocket start for further research and for further clinical interest in this new field. The largest study apart from the meta-analysis is the one published in Radiology by Sale and colleagues in this year. It was a multicentric retrospective study reporting in 530 patients. They observed clinical failure in only 6.8%. Radiographic failure, defined as a hematoma thickness reduction of under 50%, was observed in about 26%. And they performed multivariable analysis looking for predictors of clinical failure or non-failure and radiographic failure. And they found that the predictor of clinical failure was patient taking anticoagulation, a predictor for clinical non-failure, so better results for patients treated with liquid embolics, And the only predictor for both clinical and radiographic failure was a small diameter of the MMA, which is interesting and good to know for performing these procedures in clinical practice. Several meta-analyses were performed on this treatment technique, and I want to present you two of them. One is a study by Ironside and colleagues published 2 years ago. They summarized data from 20 studies reporting on over 1,400 patients, about half of them receiving embolization, about half of them receiving conventional therapy. And they found a significantly lower rate of recurrence and a significantly lower rate of requirement of rescue surgery for the embolization group. The complication rate, the in-hospital complications, were also lower for embolization group compared to conventional management, however, without achieving statistical significance. And the other group is the one, the other meta-analysis I want to show you is the one by Satari and colleagues, which was published only recently. They looked at 9 studies covering over 1,500 patients. And they found that MMA embolization is superior to the conventional management in terms of treatment failure, surgical rescue, and complete hematoma resolution. And the number needed to treat for these factors was only 3 for complete hematoma resolution and 9 for the surgical rescue. And interestingly, there was no significant difference between MMA embolization group and the conventional treatment group regarding complications, the clinical status represented by the follow-up MRS more than 2, mortality, or the length of the hospital stay. So let's get back to the question, which embolic agent is the best? Several studies addressed this question, and I want to, from my side at least, try to answer this question now. According to what we currently know, according to the evidence, both liquid embolic agents and particles are effective and safe for the embolization of the MMA for the treatment of chronic subdural hematoma. One meta-analysis published this March in JNIS focused on this question. They analyzed 22 studies covering more than 1,700 patients. They also found, as the other meta-analysis, that MMA embolization significantly was associated with a decreased odds of reoperation. And regarding embolic agents, they found the lowest rate for recurrence, reoperation, and complication for patients who were treated with onyx, and the good clinical outcome was most commonly observed in patients treated with PVA particles and coils. So what do we need now? We need randomized studies. A lot of these studies are just being performed. This is an overview of currently recruiting RCTs for MMA embolization according to the clinical trials homepage. And I think we can expect the first results about end of this year or beginning of next year. Based on the evidence, and I want to present you indications, it's just a proposal, indications for MMA embolization. Indication can be performed after a first recurrence, additionally to resurgery or alone. It can be performed additionally to surgery at the first therapy of chronic subdural hematoma in high-risk patients, for example, patients taking antithrombotic medications. Another indication is performing MMA embolization instead of surgery at the first therapy in case of contraindications for an open operation. And it can be performed for the prevention of surgery in patients with only small subdural hematomas and or only mild symptoms. And this is very important. It should be and is no replacement for surgery in case of large chronic subdural hematomas with patients suffering from acute symptoms. I want to end my presentation with a short case presentation of a 78-year-old female patient. She had headaches and mild aphasia caused by a left-sided chronic subdural hematoma. we performed embolization from the parietal branch of the middle meningeal artery. What you can see here is leakage of contrast agent into the hematoma, which is not infrequently seen. And from this position, we performed embolization, in this case with Onyx 18. And from this single microcatheter position, it was luckily possible to embolize the whole territory of the middle meningeal artery, which is relevant for this treatment technique, which is also facilitated by a wedge position in this branch. It is not in every case that you reach embolization from only one position, but we often see this. The good distribution is also seen here in the post-interventional cone beam CT, and the patient recovered well from her symptoms. At a 3-month follow-up, she had only mild headaches and no aphasia. I want to end my talk with a summary and try to answer the question, where are we? Chronic subdural hematoma is frequent and the incidence is increasing. The currently applied traditional management techniques like surgery and conservative management, they have limitations. They're only moderately effective, especially in patients with recurrent chronic subdural hematomas. MMA embolization is effective and the rate of complication for this treatment is low. Particles and liquid embolic agents are effective and safe. Maybe liquids are a little bit more effective. The data is limited, but very promising, and we are all looking forward to receiving the results of the randomized controlled trials. And this is important for all the neurosurgeons, or if you as a radiologist discuss with your neurosurgeons about this new technique, embolization can and should in most cases be performed in addition to surgery and not as a replacement. Thank you very much for your attention to this lecture.
Dominik, thank you. It was really a very clear overview of what can be done. So, of course, you address part of the topic because the rest will be addressed by Dr. Yaniv a little bit later. So it was really very clear to me. I have to remind everybody that it's a new indication of embolizing the middle meningeal artery to have those chronic subdural hematoma. It's really a revolution in the way we treat this chronic subdural hematoma. We have to emphasize for all of those who are following us. So I will ask you some obvious questions. So what's the role? So you addressed part of this question already, but I want to be very clear about that. What is the role of this MMA embolization for the treatment of acute subdural hematoma?
Well, for the acute subdural hematoma, there's no real evidence, and it does not play a role in the embolization, in the treatment of acute subdural hematomas. So the mechanism of embolization relies on dilated pathological vessels which form due to the chronic subdural hematoma. So it's important to know for acute subdural hematomas, the MMA embolization plays no real role.
So Gal will be reviewing all the technique, but we can start to discuss about the different technique. So yourself, are you using liquid embolic? I would say the overall liquid embolic, or are you more focused on the particles?
We use mainly liquid embolics, all of them, which are available.
So say it again, Dominik.
Yeah, we use liquid embolic agents, maybe the copolymer-based one like Onyx, Squid, and Phil. And
Gal, what are you using yourself?
I'm using, like Dominik, mostly Onyx, Squid, and rarely Phil. But so, I also sometimes use particles or coils. It really depends on the overall indication for the patient and the anatomy of the MMA.
So in my opinion, the negative point of using particle is just that you don't see them. So isn't it one of the major negative points of using particles? Dominik?
Yeah, I think it clearly is, and you have no real control after the treatment. Where did your particles go? And it's as you saw on the post-interventional cone beam CT, which I showed, you can excellently see where did the embolic agent go, and you see if it like enters the sinus or if you've got reflux into areas which you do not want to penetrate. So I think the control is very good.
Okay, you have spoken about the diameter of the MMA. So there is one question on the chat which is asked by Paul Alanis. At which level do you perform the measurement of the diameter of MMA? Do you have an answer of this for this quote scientific question?
Well, in this publication which was performed, it was measured in this straight part before the bifurcation, so after the foramen spinosum. But in clinical practice, we never measure this vessel. Well, you look at the vessel and you see, okay, will my catheter go into this vessel? Sometimes you have like tortuous anatomy of the MMA as well, which might make it difficult to navigate your catheter distally enough. But it is more, like you said, it's an interesting scientific question, but in clinical practice, I think the relevance is not so high for the exact diameter.
I have a question for you, Gal. I know that you will be addressing this subject. It's about using particles. There's a question from Dr. Swell Akhtar, who is asking which size of particle is good to use. Do you have an answer for this question?
I have like a textbook answer because usually I don't use particles. As Dominik said, I think it's more dangerous than other options. And when you use particles, it's always you need to consider between not too small for them to penetrate to the capillaries and go away, and not too big to clog your microcatheter. So it really depends on the diameter of your microcatheter. You need at least a 21 or 27 microcatheter, which is a limitation sometimes for navigability. And I think in most places they use between 150 and 200 micron microspheres.
So just to emphasize for everybody listening to us, so personally I don't like the particles, because if you have an opening of an anastomosis, a dangerous anastomosis, that you don't detect that. Conversely to the liquid embolic, which are highly visible, and even the glue is also highly visible thanks to the lipidol. So last question for you, Dominik. You said it, but can you say it again? Which concentration of onyx are you using for the embolization of the MMA in this indication?
We use onyx 18.
Okay, yeah. Never use the other concentration, the more viscous concentration of onyx?
Not really. We use the lower viscosity versions of the other manufacturers, but I think they might be too low in viscosity. Like Squid 12 Fill LV might be too less in viscosity, I think, for an effective and safe embolization.
After the talk from Gal, we'll be discussing about the cost, but just one quick question. Usually, how many vials of onyx do you use per patient?
Most of the times, not more than one.
Okay. So let's move to the second part. Now we'll have Gal Yaniv from Tel HaShomer Hospital in Tel Aviv, who will be giving the second talk that will be completely different topic from what has been addressed by Dominik. That's for you now, Gal.
Thank you for the introduction, Professor Spelle, and thank you everyone for attending this webinar. Yes, my lecture will be a little bit different. It's more about the technical aspects of the procedure. It's more a practical approach to how to do an MMA embolization. These are my financial disclosure. So I'm going to talk today in the next 20 minutes about these subjects, which are all important, and each one of them can be a separate lecture by itself, but I'll try to be as precise and accurate as possible about each one of them. We're going to talk about the anesthesia part of the procedure, puncture site, access of MMA, which branches of the MMA to embolize and how many of them. Do we need to embolize the entire MMA, just one branch, proximal, distal, whatever? Which embolizer to use, and I will try to address a few areas that Dominik didn't talk about them. The technique of the embolization itself, very important major risks of the procedure, and how to do the follow-up for the patients after the MMA embolization. So regarding anesthesia, when we start the procedure, we can talk about whether to do a general versus a local or sedation anesthesia. And we need to remember that the MMA embolization, the chronic subdural hemorrhage population, usually are older population than what we're used to, especially with shunts and aneurysms. They have multiple comorbidities, and this also can be affected by the embolization material that we want to use. So when do I think that one can use local or just a sedation for the patient? And just to make to be clear, the vast majority of our patients, at least, are under general anesthesia. But sometimes you need to use local or just local anesthesia or sedation. So when we did this amount of anesthesia, usually it's because we have a good anatomy, or the patient is high risk for anesthesia, for general anesthesia, because of severe cardiovascular comorbidities or severe pulmonary hypertension. But when we do local anesthesia or sedation, we can use only non-painful embolization technique like coils or particles or NBCA, because we know very good that DMSO-based glues like onyx or squid are very painful during injection. Even intracranial injection is painful. So when you inject DMSO next to dura mater, this can be very painful, and usually patients don't react very good to that when they are not under general anesthesia. So the vast majority of our patients are under general anesthesia, and we use general anesthesia for patients with freaky anatomy, and with older population, the vast majority of them has tortuous anatomy, either at the aortic arch or climbing up the ECA. A lot of times, this is patient request, not to feel anything, and just to be under general anesthesia. And as I said, when you use DMSO-based glue, I think it's a must to do general anesthesia. Regarding puncture site, so usually we either do femoral puncture or radial puncture. Again, what are the consideration points for that to decide? We have older population. A lot of them have atherosclerosis, can be in the iliofemoral arteries, descending or aortic arch, which can cause thromboembolic complications while climbing through a femoral approach. Difficult arches, the vast majorities of older patients has tortuous anatomy and abundance of type 3 and bovine arch aorta. And a lot of them has also abundance of anticoagulation or antiaggregation drugs. Although I must say that antiaggregation drugs are not as problematic as anticoagulation compared to complication of the puncture site. Why to choose femoral? So femoral, I think for the vast majority of the neurointerventionalists, femoral is more intuitive. This is the basic technique that we use. And technically it's less challenging. The femoral artery is usually a large artery. It has a very easy access to the aorta. And of course, the vector of pushing the system up through the femoral artery is different compared to doing it from a radial approach. We can use larger bore systems like 8 French or 9 French if someone uses that, while radial approach is limited to 7 French in 2.5 millimeter size radial arteries and above. And of course, there are no radial complications such as spasm or stuck catheters because of spasm, and radial loops that can really hamper the navigation. Why to use radial? And I must say that specifically at our institution, we're moving more and more to a radial approach. And mostly because we don't experience any groin complications anymore. And groin complications can be devastating sometimes. We're talking about extra or intra or retroperitoneal hemorrhage, which can be very problematic, especially this age group. There is no need for prolonged bed rest following procedure, which is a big advantage for this patient population. Sometimes radial access has a better access in difficult arches compared to the femoral approach, especially with bovine arch, and this is something that has great advantage of a femoral approach. And another advantage is that there are new dedicated radial systems for neurointerventionalists. We have a lot of experience of the WRIST 079 system by Medtronic, and we are going to start using also Armadillo 0.072 catheters. And it looks like the entire field is going more and more radial, and I think it's a good vector for us. And a lot of patients are starting to request more and more radial approach because either they experienced femoral punctures before or they heard that it's better. This is a recent example of MMA embolization of a 79-year-old through a radial approach. This patient was MRS0, was taking apixaban for atrial fibrillation. He had a bare hole at the beginning after diagnosed with a chronic subdural hemorrhage, but 1 month later, this hematoma actually grew. So he was referred to us by the neurosurgeons to do MMA embolization. We did a radial approach with the wrist catheter, and we used we didn't use any DEC catheter. We just used the wrist catheter and a sonic 1.2 25 millimeter detachable tip microcatheter over a hybrid microwire. And we used Onyx 18 for this approach. Usually we give some nitroglycerin after insertion of the 7 French sheath into the radial artery, giving systemic heparin, and then climb into the arch. In the arch, we actually used SIM2 select to select the left side, the carotid. And because of the great trackability of the wrist was actually placed next to the IMAX in the external carotid, actually, which didn't caused us not to use any DAC, but just to use the sonic through the wrist catheter. We used the sonic 1.2 microcatheter. Usually we navigate as distal as we can to create a wedging position. And we inject Onyx 18. This is the cast. It's not very distal. It's more proximal. And we were happy with that. We didn't embolize the posterior branch as well because of a great proximity to the petrosal branch, which was dangerous. And as you can see in this image, the petrosal branch was saved, and the patient actually woke up fine. And this is a new patient, so I don't have any follow-up CT yet. And maybe I can update later. How to access the MMA? So to access the MMA, first of all, MMA usually comes out from the external carotid artery. This is the largest branch and largest ascending first branch from the imax, which enters through the foramen spinosum. And the foramen spinosum, of course, is a very important anatomic landmark because it actually shows the origin of the petrosal branch, which is very important not to embolize because of reasons we will discuss in the next few minutes. After crossing the foramen spinosum, usually we select either of the branches. We will talk later. Most of the time, we use a 7 French system, a triaxial system, and we really like the small duct when the guiding catheter does not climb all the way into the imax to give extra stability and give better, let's say, control of the microcatheter and microwire while trying to access the MMA. Our go-to small duct is usually a Phenom Plus. Sometimes we use Fargo Mini by Bolt, but we found it a little bit stiff and cause spasm, so we mainly switch to Phenom Plus. The duct is usually placed close to the MMA origin, and if possible, and the MMA is large enough, we even put it inside the MMA for better support, so we can push the microcatheter as distal as possible. And we use a detachable tip, 1.2 or 1.5 microcatheter, mostly because we use Onyx, either Sonic 1.2, the versions between 15 and 35, or the Apollo 1.5, 30 or 50 millimeter detachable tips. The principles we use to navigate the microcatheter is, first of all, distal as possible. This is important because you want to create wedging and you want to avoid any collaterals that you can either see or, more importantly, don't see collaterals, mostly intracranial or intraorbital collaterals, which are very dangerous. If we need to choose either of the branches, usually we try to localize the branch that is the dominant one and approach him first. If there's like a laterality of the hematoma, it's more frontal or more posterior hematoma, we'll go to the branch leading there. And of course, if we're too close to the petrous branch because of difficult anatomy, because of tortuosity, whatever, sometimes we will switch to another microcatheter that can enable us to use more safe embolizers such as coils, again, I don't like to use particles, and I don't use particles, so coils or glue, but usually not particles. This is a very, very important article that was published in 2022 by a Boston group, which actually investigated, I think, a very important question. Which MMA branches or branch do we need to embolize? Do we need to embolize the entire MMA? 2 branches, 1 branches? Do we need to insist on a very distal embolization of the MMA, as Dominik showed in his beautiful case, with onyx penetrating right into the hematoma, or we can just embolize proximally enough just to break the vicious cycle and give the dura mater the ability to absorb more blood that is spilled by the capillaries, the abnormal capillaries. And the conclusion is astonishing. It actually says that the outcomes of distal, proximal, or combined proximal and distal MMA embolization is not significantly different, which actually means you can embolize whatever you want. It can be distal, it can be proximal, it can be 1 branch, 2 branches, and still, in the vast majority of patients, the clinical and radiological response will be very good. And this is extremely important because it can actually say that we may need, it can be a very small, technically easy procedure. Just go inside MMA, make sure you don't have any dangerous anastomos, do a small injection of probably a DMSO-based glue, and that's it. Your patient is done, instead of not wasting, but investing a lot of time navigating in the MMA, trying to create distal embolization, which I'm not sure is very effective. And in our practice, a lot of times we just do this small injection. And I must say that after a few dozens of cases, we see excellent results from whatever technique or whatever distance of glue that we achieve during embolization. Which embolizate do we want to use? So again, Dominik talked about it. I don't want to talk about it too much. We have coils, we have detachables coils, we have pushable coils, we have NBCA, we have particles, we have and we have DMSO-based glue or NBCA. And again, my favorite glue is onyx or squid. It really depends on the position that I reach with the microcatheter. If I have a good wedging, I'll use it. Usually, I'll use onyx 18 to push forward the glue by the wedge, like a wedge pressure cooker. And if the wedging is not very good, sometimes I will use squid 12 just to try to penetrate as distal as possible. But again, I see excellent results from both of them. And I think both of them are good. I mean, they're equivalent in their ability to create a good clinical and radiological response. For some reason, I can't switch. Regarding microparticles, I really agree with my colleagues. I don't like them. I think they're dangerous. They are, you know, the first reports were about particles, but since then, I think DMSO-based glues are more abundant and more in use. Microparticles are quite simple, most of the time safe, and they have distal penetration. The drawbacks is you can actually don't see them. So again, if you have dangerous anastomosis, you can actually just embolize this anastomosis and you don't know. They need large warm microcatheters, and it's only a temporary occlusion. I'll go a little bit faster just to make sure I'll be on time. Regarding liquid embolics, I think Dominik talked about it a lot. And again, we have a lot of experience with that. You can create wedging and create distal embolization or proximal embolization. Probably both of them are effective as well. Regarding major risks, so the two major risks during MMA embolization, and this is very important, are either ophthalmic artery risks or facial nerve risks. And regarding ophthalmic artery, that means that there are a lot of dangerous anastomosis between ECA branches, especially MMA and the ophthalmic artery. And you can actually create embolization of the ophthalmic artery, which will cause a monocular blindness. And again, the petrosal branch, which, as we said before, exit around the foramen spinosum, and embolization of the petrosal branch can actually cause a facial nerve palsy. So this is an example of it's quite rare, but you need to make sure you don't miss it. It's MMA originating from the ophthalmic artery. Of course, it's a no-go, no way you can do, and I mean you can do, but it's high risk for eye blindness to work through the ophthalmic artery. Always remember the meningo-ophthalmic and the and the meningolacrimal arteries collaterals that can create blindness through these dangerous collaterals. So always, when you inject the dye, make sure that you don't see anything go, into the orbit to show you that there are dangerous anastomosis over there. Again, this is the petrosal branch, which is in charge of the facial nerve exiting from the internal ear. We know that the ICA is in charge of the intracranial portion of the facial nerve, and after that, the petrosal branch of the MMA. And embolization, especially distal embolization of this branch, can cause facial nerve palsy, which again is a very unpleasant complication. But having said that, we know that the complication rate is very low. Also in our experience, we're talking about between 1 to 1.5% of complication rates. And as long as you follow the rules, you should be fine. Regarding follow-up, usually we do a non-contrast CT at 1, 3, and 6 months after the procedure. If the patient was taking antiplatelets before the procedure, we resume them the day after the procedure. Patient taking anticoagulation, usually we'll switch them to Clexane, and we'll switch them back to anticoagulation after 1 month of follow-up with non-contrast head CT, just to show any kind of response, and of course that there's no increase in the size of the hematoma. And until now, we haven't seen any surgical rescue from other of our patients undergoing MMA embolization. And this is another case I want to show you, but I'm a little bit short of time. But briefly, it's a 96-year-old lady. She's an MRS1. She had two bilateral big chronic subdural hemorrhage. Neurosurgical team didn't want to operate on her, and she hadn't has any laterality in her neurological deficit, just headache and some unspecific neurological complaints. So we did bilateral MMA embolizations in 2 weeks apart. Again, this was from femoral approach. Both of them were quite proximal embolization, and this is the result. This is 6-week follow-up CT, and this is a 6-month follow-up CT of this 97-year-old patient, which show great success of the embolization. Regarding take-home messages, like Dominik, I think that there are still no definitive guidelines for which patient to take, what is the timing, and which technique specifically do we need to choose. We still need to wait for these randomized control studies to understand much better these questions. This procedure have high efficacy and low complications rate, which makes them very good choice for patients and referring physicians to do this embolization. And I think the numbers will increase over time for larger number. That's it. Thank you very much.
Gal, thank you. It was very clear as well, and it brought, I think, to the community a lot of important information. So we don't want to spend too much time about which material is the best. We have said already that everything can be used. There is absolutely no scientific proof that one is better than the other. We just said that if you are not having a lot of skill, using the particle might be a little bit trickier. So we have a remark from Dr. Christine Blackham, and she says, of course, we don't see the particles, but everybody knows that we mix them with dye. So for sure, we can see where is going the dye, but it is diluted, and usually the visualization is very fleeting. So for those who are not very aware, in my opinion, it's a little bit tricky to use a particle. What is your comment for that, Gal?
I agree. I mean, we don't see the particles, we see the contrast. And we can never be sure enough where these particles go. Also, your indication when to stop injecting the particles is when you have stasis of the iodine. But that doesn't mean that particles just don't reflux in the MMA into the external, and who knows where they go.
So you have insisted on the dangerous anastomosis. So we have to pay tribute to Maxime Shapiro, and you have views of this schematic drawing, which are beautiful. You can check them on neuroangio.org. And please, before doing this kind of embolization, you have to remember where and what are those dangerous anastomoses. So there is a question, I don't remember who has asked the question in the chat, regarding the usage of vasodilatator for MMA. What is your advice?
In Israel, we can use nimodipine, IV nimodipine, and for the guiding catheter and the duct, usually we put a saline flush with nimodipine inside it. When we encounter some kind of spasm that, again, we can't control with the nimodipine, we usually inject just a few drops of nitroglycerin locally over Rapamil and wait a little bit, and usually it solves the problem.
So we are a little bit overloaded with questions and remarks on the chat, so it will be difficult to address all of them. So I will be going through different, for some of those questions. So this is for you, Gal. It's about the anesthesiology. So somebody remind us, it's Paul Alanis, that most of the burr holes are made under local anesthesia. So is there any rationale to use general anesthesia in this elderly population? What is your comment on the anesthesia for those patients?
Unless there is a contraindication for general anesthesia, I usually prefer to do this procedure under general anesthesia because, again, you need to be much more careful with these patients. The navigation is a little bit more tricky. You have a lot of atherosclerosis and plaques, and these patients usually have other comorbidities. They are not very comfortable not moving for more than 10, 15 minutes, and I think it makes everything a little bit more dangerous when they wake up.
Dominik, what is your comment about the embolization on your side?
It's exactly the same as Skal said. Yeah, if the patient is not suitable for general anesthesia, we do it in local. But as Skal said, it's same in our department. If general anesthesia can be performed, we also prefer this because it makes the procedure more convenient for us, for the patient, and I think safer too in the end.
I do agree with you. In the department, we do also under general anesthesia. So there is a comment from Alessandro Pedicelli and also from Mohamed Gormadi in Tehran, and they propose this 1 cc of xylocaine intraarterial. Have you any experience about that when you perform under sedation?
Not for me. Usually if I do the procedure under sedation, I'll try to use coils, push coils or detachable coils, something that it's not painful.
Dominik, what is your answer regarding usage of xylocaine IA?
We never use xylocaine IA for these procedures, no.
Okay, so what about, Gal, what about the bilateral subdural hematoma? Do you embolize both MMA within the same session?
No, usually I don't do it in the same session. There's no specific reason. I just try to make the procedure as short as possible because of this population, especially the example I showed with the 96-year-old lady, which was very fragile. But I don't see any specific contraindication if everything goes well not to embolize bilateral MMAs.
I have a difficult question for you, Dominik. Is there any specific patient characteristic or comorbidities that influence the outcome of this MMA embolization?
No, as if we look at the literature, the only thing that was reported is that for patients taking anticoagulation, that they respond worse to this treatment. So yeah, I think it's the mechanism is obvious. So there's only evidence for this factor, that patients taking blood diluters, the outcome might be not so good.
So Gal, what is your comment about the penetration aspect of the onyx? So it's completely disappointing compared to the penetration of onyx within the brain AVM. Do you have such an experience?
Yeah, I mean, we at the beginning we try to be as distal as possible, but sometimes you just have you just have a lot of reflux and you can't be distal. And we noticed during the following months that these patients, the proximal occlusion patient, actually reacted very, very good to this procedure, like the distal penetration patients. So actually now we do not insist. We just go to the most dominant branch. If we can do 2 branches, inject a few drops of onyx, make sure that the branch is occluded, and make like a 30-40 minutes procedure.
So there are so many questions. We will be ending with 2 questions. The first one is for Dominik, which is, does the timing of embolization have an impact of the outcome of this embolization?
As far as I know, no. There's no evidence or no study on like timing, if you perform it before surgery, if you perform it after surgery. I think we do not know.
So thank you. It's impossible to end this discussion without speaking about the price of such an embolization compared to the surgery. Of course, it's a little bit disturbing debate because it depending where is performed the surgery, in which country, the mechanism of reimbursement. But dealing with your own country, how is reimbursed the embolization of MMA compared to surgery? Gal, I'm sorry.
I don't have a specific numbers, but from my knowledge, MMA embolization costs much more than a bear hole, which is a very a very short procedure, very easy procedure, short time of ER. While MMA embolization, you use catheters, you use glue.
Dominik, what's your comment on your side in Germany?
Yeah, there's one interesting, it's not from Germany, but from the US. There's one study which looked at the 1-year total hospital costs for comparing these 2 procedures. And they found that not the procedures themselves play the important role, but that the number of reoperations was much higher for the surgical group. And this created a much higher cost for the procedures. So, yeah.
So unfortunately, we have to close this LINNC Online webinar. I would just have to summarize to have a take-home message. So the advantages of the MMA embolization is that it's improved the patient care. It's a lower cost and hospital stay. It expands the field of our discipline because it creates more daytime cases as the demand for urgent mechanical thrombectomy increases. So this is for sure a parameter that we have to take in account. So the procedure by itself, if I look at what has been said today by Dominik and Gal, it's fast, technically easy, I would say boring, but it's a personal comment. It's safe, it's effective, but up to now in uncontrolled series, and it's definitively a way to diagnose and treat cognitive and physical decline in the old people. So the embolization acts as a standalone therapy to avoid eventually the surgery, but it may act also as an adjunct to the surgery to reduce the recurrence. Finally, there are so many ongoing trials. Most of them are randomized trials. This has been listed today, and you have at least 10 or even more trials that will bring the answer to all those scientific questions very soon. So thank you to you, Dominik. Thank you to you, Gal. I would like to have a special thanks to Medtronic and Nadine Hans. Special thanks to all the Europa team here who was animating this first LINNC Online webinar. This webinar will be available for replay on the LINNC Online platform in the next few days. Very last comment, Dominik, do you have any short comment to make about this technique and the indication?
Yeah, we're looking forward to the randomized controlled trials, and I'm very, very, looking forward to what the future will bring regarding this new treatment.
Okay, bye-bye, Dominik. And last word for you, Gal. Do you have any last comment that would be important for us?
Yeah, I agree with Dominik. I think we all look for the RCTs, but I think all of us who do this procedure and see the patients after the procedures know it's a very good procedure, almost no complication, and I'm sure we'll get more and more numbers with that in the future.
So thank you to everybody all around the world for listening to this webinar. I'm very sorry that we were not able to answer all those questions, but I think you have answered most of the questions that were asked today. Bye-bye to everybody, and see you soon.
Bye-bye.